providers, in particular in low-middle-income countries, prescribe unnecessary antibiotics. And I think it's quite an interesting topic because, generally speaking, people have been looking at the issue of underuse of care in low-middle-income countries. So why do people don't get treatment when they need it? But actually there is a huge problem relating to overuse of care. It's a waste of resources for the system and or for the patients who also have very limited means. And so I've been looking at this issue of overtreatment and specifically looking at the question of antibiotics, because prescribing antibiotics when they're not necessary means that there will be problems in the future. So economists talk about negative externalities, with bacteria becoming resistant to these antibiotics and having new diseases that we can no longer treat properly. And so I've been looking at this question so far in South Africa, where it's quite an interesting context to try and test a number of ideas, of hypotheses, to try and understand, well, why do we see these over-prescribing of antibiotics? So the first thing we wanted to test is that when you talk to providers, when you talk to doctors and nurses, they say, oh, it's because, the reason why there are too many antibiotics that are being prescribed is because patients are asking for it. Patients are requesting antibiotics, and so we have to do that. And so we put that theory of that idea to the test by using standardized patients. So we trained people, normal people, to go and visit doctors in the public and private sector in South Africa and present themselves with the symptoms and the history of a very uncomplicated viral infection, bronchitis, that do not require any antibiotic at all. And so what happened was a huge overprescription of antibiotics. So I think in total we had about 72% of our patients who received antibiotics for a condition that did not require any antibiotics at all. So the providers who had seen our patients were interviewed. We try and interview as many as we could. And the vast majority of our providers who had been prescribing antibiotics were still telling us that this fake patient suffers from a viral infection and therefore should not get antibiotics. So it was not a problem of knowledge for the majority of these providers. What we realized was that if we looked at the probability of prescribing an antibiotic, it was much higher in the afternoon than it was in the morning visits. And this is consistent with some findings from other settings, which show that to some extent it's when habits kick in or kick back, when providers, doctors have been busy and are a bit more tired, and then their bad habits come back. We tested two different ways of trying to limit this over prescription of antibiotics. So the first thing was tested, what would happen if we had an incredibly successful public awareness campaign, which would sort of empower patients and raise awareness within patients and get patients to question the appropriateness of having antibiotics or not. So we sent these standardized patients and we trained them to tell the provider that they would not want antibiotics unless it was really necessary. There was a significant decrease in the proportion of patients who received antibiotics, but we still had about 1 in 2 patients who still got these unnecessary antibiotics. And then we tested another potential solution to try and reduce unnecessary prescribing of antibiotics. So we limited that particular study was limited to the private sector. We do see that these dispensing doctors tend to prescribe cheaper treatment and tend to prescribe less antibiotics than doctors who don't, who can just write a prescription and give it to patients. So when the price of the treatment was included as part of the consultation fee and was effectively reducing the profit of the doctor, we found that doctors recommended cheaper drugs, fewer drugs. However, unfortunately, there was no change for antibiotics specifically. Unfortunately, as a result of our study, we could not provide a sort of silver bullet solution or a magical answer to policymakers, to the local and national policymakers we were talking to in South Africa. And so we are currently testing and well, hopefully we will get a study funded to test a new idea that we have to try and limit overprescription of antibiotics by working with local clinicians, local policymakers in Johannesburg to try and create a way to limit unnecessary prescribing of antibiotics by making it a little bit harder for providers to decide to give antibiotics to patients.